Hello everyone, welcome to our first webinar in 2024. We will start our webinar in 6 minutes. Still have some time left to wait for more attendees. And for this webinar, if you have some questions, please put it in the Q&A box. And our speaker will ask you questions when she sees it. Please feel free to ask any questions. Thank you. Hello.
Hi,
Hello.
Jason. How are
Hi.
you?
Hi, Dr. Vasiliki. Yeah, fine, thank you. Yeah, we still have 2 minutes to wait for
Okay, that's
attendees.
great.
Yeah.
That's great. And you received also the case that I have sent you,
Yes, I've received it.
but we will present it today as well. Let me
Cool.
just check something.
Okay. Okay, I want to say welcome to all the attendees to our first webinar in 2024. So our Dr. Vasiliki is waiting, and if you have some questions during the presentation, please feel free to put it in the Q&A box. Dr. Vasiliki will be very happy to answer your questions. And we also have our monthly cases on our YouTube channel. You can scan the QR code to subscribe us for the latest cases.
I want to wish everyone a very happy new year. And I'm very happy that we're going to do the first webinar all together. And we have a multinational audience from a lot of different countries, which I'm very, very happy about. Whenever you're ready, Jason, you tell me and I will share screen.
Yep, I think it's time to give you the host. Just wait. Okay, now you are the host. Now you can share the screen. Cool.
First of all, I want to wish a very, very happy and productive new year to each and every one of you, with prosperity, with happiness, with all your goals fulfilled, and with many, many more interesting cases, and also with curiosity. Approach everything with curiosity. We're going to talk today about functional and mechanical pyloric obstruction, which is very, very common in the everyday practice. And there is a definite distinction between these two entities. And we're going to dive into cases mostly and how this situation can arise. And the next webinar will be on treatment, because I know that a lot of you are really curious about what are the updates on prokinetics and prokinetic treatments about delayed gastric emptying. And to be honest, there are a lot of new things out there. So we're going to dive into treatment and more cases on pyloric obstruction, both mechanical and functional, mostly on the functional part. Please feel free to put your questions in the chat box or to the Q&As section, and we will have an interactive discussion, because actually what I want us to do is to create an endoscopic community where we can exchange. And I know that with many of you, I have this relationship that after each webinar, we can discuss cases and see each other through Zoom calls. So this is wonderful for me, because I learn from you as well, and from whichever cases you encounter. So gastric hypomotility disorders, and especially outflow obstruction, because this is what we're going to talk about today, about outflow obstruction, is an entity that actually has two major components, the mechanical part and the functional part. And the mechanical obstruction can be a result of a neoplastic disease that could cause pyloric stenosis, pyloric obstruction. It could be foreign bodies in the area, but it could also be underlying diseases like the hypertrophic piloropathy. There is a complex of diseases that actually cause fibrosis to the pyloric antrum, or mostly focused on the pylorus. It could be a diffuse disease, could be a more localized disease. So it could be hypertrophic piloropathy, it could be hyperplastic mucosa only of the pyloric antrum, or a more diffuse disease could be hypertrophic gastropathy and gastritis. Sometimes we have an obstruction of the pylorus due to external compression from enlarged liver or an enlarged pancreas, by duodenal masses, or we could also have a very rare disease like duodenogastric intussusception. If any of you has encountered duodenogastric intussusception, I would be very interested to discuss it with you, because rarely have I ever encountered similar diseases. And the second pillar is the functional obstruction, which is not an actual obstruction. It is mostly a gastric hypomotility disorder that does not promote the content of the stomach into the duodenum. It could be due to fibrosis of the region as well, and we will see one of these cases today. It could be attributed to primary gastrointestinal disease like inflammatory diseases, eosinophilic, lymphoplasmacytic gastritis. It could also be due to gastric ulcers that cause fibrosis to the pylorus and secondary functional obstruction. It could also be attributed to extraintestinal diseases, any extraintestinal disease that cause vomiting, like Addison's disease or liver disease or kidney disease. Pancreatitis is a very major component of extraintestinal diseases, because it can cause intractable vomiting and gastritis, and then that will lead to pyloric stenosis due to fibrosis. Electrolyte disturbances, peritonitis. We have cases of bile peritonitis, for example, that led to pyloric stenosis due to intractable vomiting again. We should also mention actually the input of some drugs like the cholinergic antagonist, adrenergic agonist, or opioid agonist that cause dysmotility, gastric hypomotility. And if you have noticed, for those of you who are surgeons, you might have noticed that there are a lot of cases of gastric dilation and volvulus that after GDV, we have hypomotility, gastric hypomotility. And this is always associated with significant myoelectrical, as we say, in motor abnormalities. And we will say what we can do about these cases in the next webinar, where we will talk more about treatment. Because we have a lot of GDV patients, that we perform the surgery, and then they keep on having regurgitations and vomitings, and we do not know, without any gastric content being promoted into the duodenum. And we don't know what to do with these cases, because they still, even after the surgery, they can have distension, abdominal distension, not torsion, because they have already performed maybe gastropexy and the surgery of GDV, but we still have cases that can have an abdominal gastric distension. And this is a very, very simplistic picture of what pyloric stenosis is. It's actually a narrowing of the opening between the pylorus, and so the content of the stomach cannot be promoted to the duodenum, and we have gastric stasis and gastric paresis most of the times. So gastric paresis could be the cause, but it could also be the result of that. What endoscopically, the findings that we have when we have an obstruction of the pylorus is when we enter the stomach, we have gastric stasis and gastric paresis. We have a retention of big amount of food, either partially digested food or gastric fluids in the stomach. And when we get in and we see such a big amount of retention, then we definitely have to think about pyloric stenosis, especially when we have fasted the animals for more than 12 or 14 hours or 16 hours sometimes, and we get in for an upper GI endoscopy, and we still see a huge amount of fluids in the stomach. Thickened rugae, not completely flattened by the insufflation. So we insufflate. When we insufflate and when we put air in the stomach, the rugae, the gastric rugae, should be vanishing. Instead, when we have hypertrophy, when we have this hypertrophic pylorogastropathy, then the rugae are not vanishing. This finding is very, very pathognomonic of the hypertrophic pylorogastropathy. And I'm going to show you a case here where the stomach actually looks like the brain. You see that on the right side of the image, now we are in J maneuver, because I can see my scope. Okay, I'm seeing the fundus of the stomach, and you can see that the stomach actually on one side looks like brain. I'm insufflating and I have over distension of the stomach, yet the rugae are not vanishing. We can have edema if my delayed gastric emptying is due to an underlying disease like inflammatory bowel disease or an infiltrative disease of some kind. And we can have diffuse or focal disease, either diffuse to the whole stomach, as we said, or localized in the antrum, or localized only in the pyloric region if the problem is, for example, the foreign body. And what about the first part, the mechanical obstruction? The causes for mechanical obstruction could be the congenital thickening of the pyloric smooth muscle, which is a disease process. It could be acquired due to hyperplasia of the smooth muscle of the gastric mucosa, and the acquired form could be secondary to infiltrative diseases, could be neoplastic diseases that obstruct the pylorus, it could be foreign bodies, it could be polyps. And as we said, the extra gastric compression from enlarged liver and pancreas. We have certain breeds that are overpresented, like the Boxer, the Boston Terriers, the Maltese dogs, Pekingese, all the brachycephalic breeds. And in cats, the Siamese cats. And here we have a gastroesophageal reflux disease and pyloric obstruction due to the foreign body. And sometimes you really have to, this is a thread, actually, this is shoe lysis. So you're going, if you have a linear foreign body, you're going to untangle the whole foreign body, going from the one edge and then going back to the pylorus and picking it up, and then going back to the pylorus and picking it up, so that you can see if this has proceeded into the small intestine. You can take out what's in the stomach. You cannot take what's out in the small intestine. So You can have a cooperation with your surgeon, probably, to do an enterotomy, cut the linear foreign body from the intestine and let the free edge into the stomach so that you avoid the gastrotomy as well. It's better to have one section than two, and I know that many surgeons will argue that this will take, more time, but it's always better to have less sections in the body. So as you can see, I'm trying to figure out the tension that I have from the foreign body. Do not over push. Do not overdo it in pushing. Once you feel that there is a resistance, then you should go back to the pyloric region and see if your foreign body has progressed, has actually be promoted into the small intestine. So I'm just taking it off now. I'm in the esophagus, and I'm just taking it off up until I just test to see how much of a resistance I have. And once I realize that I have much more resistance than expected, I will not proceed into grasping the foreign body out. I will go in again and again to just pick up bigger chunks of the foreign body, because this looks like, a material, like a ball material now. It doesn't look like a foreign body, and I have to slowly, it needs a bit of patience, slowly take it out in parts. Okay. If you have any questions on those things, I would be more than glad to answer them. This is a long procedure. Let's watch a bit the video. You will, after these procedures, after you have removed a foreign body from the esophagus, what I want you to do is always wash the esophagus, because we might have, from the gastric content that we have brought up to the esophagus from the stomach, we could have secondary esophagitis. And both in humans and in animals, we tend to flush the esophagus afterwards so that we can avoid at least the esophagitis. So I'm trying to bring it up. I'm not succeeding because I have tension. So eventually I will go back to the pyloric region to see what I have accomplished and what's left there to pick up. You will bring as much of the foreign body as you can into the esophagus, and then you will go back into the pylorus. Then close the sound of that. The most difficult part is the cardia, the gastroesophageal sphincter, which is very, very tight sometimes. And what you can do to avoid that is, what you can do, please, Ahmed, if you have any questions, I'm here. Because somebody raised his hand. So the most difficult part, as I was saying, is to bring it up as a mass, the foreign body. So what could help here is an overtube, actually, to use an overtube so that you can keep the cardia open. Okay, so I'm going out, I'm going again in. In the stomach, in the pyloric region, to bring some more. We're gonna go in again. I'm sorry, it's a non-cat video. That one. And you see what we're doing in the endoscopic hole. We've brought a lot of the foreign body up to the tongue, but we cannot take it out. So don't push it if you can't take it out. Don't push it. You will go back in. So we went back in, as you see. And we're trying to see, you see how big of a mass it is. It's stuck in the pyloric region, all this mass. So we go in and we're trying to take it out slowly, gradually. The video will be available for those patient colleagues that okay, Ahmed, I can see, but we will send you the link afterwards. Don't worry. So for those of you who are very, very patient to watch the whole video, I will send it to you. So we're trying gradually to unravel, you know, the whole mass of the foreign body, and then we're going in again and again, as I said. It's a big video and a big effort, but we actually were able to take out the foreign body. Okay, let's go and see now. What about when we have a mechanical obstruction due to a neoplastic mass? And this means that the pylorus, the flow, the gastric outflow is obstructed by a mass. So you get in, and the first picture, the first vision that you see is this one. So you see gastric contents just staying there, over distending the stomach, even after 16 hours or 24 hours of fasting. And what you have to do, first of all, is take out all and flush out and take out all the suction out, all the fluids, so that you can see what's going on. But the minute you get in, you can definitely diagnose that there is a gastric stasis for some reason. You don't know what it is yet, but after you have taken out all the gastric fluids, then you're looking for the pylorus, and you see that the pylorus is here, and just overlying the pylorus, there is this huge mass that's actually obstructing the entrance to the pylorus. I was actually able to get into the duodenum, so the obstruction was not total, it was partial. But the mass in the pyloric region was actually making the stomach, was causing gastric hypomotility. So there are a lot of components. It's not only the mechanical obstruction, but it's also the functional obstruction that the mass at this region is causing. Okay, and this was an adenocarcinoma in this dog. You can see how big the mass is. And now with the new scopes, we can actually see the neoplastic metaplasia in other areas of the stomach as well. Let's go to a case and let's discuss the first case. This is Apache. It's a Malinois, which is, a variety of a shepherd dog, 10 months old, a puppy, male intact. And he has been having intermittent vomiting of 3 weeks duration. He was actually given all kinds of antiemetic agents and anti-secretory agents like PPI inhibitors, ranitidine, maropitant, amoxicillin, but very poor response to every antiemetic treatment that this dog had. Did we do a surgery at the pylorus? In the previous, yes, we did. And I'm going to show you the surgery that we perform, the surgeries that we perform. Yes, we did. But these animals do not have a good survival rate. And chemo, yes, but the stomach, and especially if it's not lymphoma, then you're in big trouble. Adenocarcinoma, sarcomas in the gastrointestinal tract do not have a very good prognosis unless they are localized as a mass in the intestine when you can do enterectomy. Enterectomy, correct. Okay. Not enterotomy, enterectomy, and anastomosis. So in the stomach, it's a bit difficult. And what they have tried in several research papers is that they have tried to actually resect the whole stomach sometimes. And this is what they do in humans, and connect the esophagus to the intestine, which is not very, very successful. Actually, it's very unsuccessful in dogs. And it has a very, very high mortality rate. So these animals are actually prone to dying. You can only do palliative things. Let's go into this case, and we're going to discuss about it. So we have the content of the vomiting was bile, it was gastric contents, it was undigested food. It had no correlation to meals. So the animal could consume the meal and vomit right after the meal, or it could also vomit, 12 hours after the meal. We have acute episodes during the last 3 days of projectile almost vomiting. So it was intractable, even if the animal was under maropitant and ranitidine and other antiemetic agents. And during the deterioration and the increased frequency of the vomitings were prominent even when the animal was fasted. So the animal was just having projectile vomitings of bile when it was fasted, or of gastric content when it ate, when it had meals. In the beginning, the appetite was normal, but progressively, we had depression and, of course, anorexia. What about a clinical examination? The heart rate was 52 beats per minute, which was, this dog is not bradycardic, but you would expect that a puppy that's on the examination table would have more, more increased heart rate. So we always tend to think about Addison's disease when we see a puppy or a young adult dog that has vomiting episodes, intractable vomiting episodes that do not respond to common antiemetic treatment. We tend to be suspicious of Addison's disease. Okay, the pulse was strong. The mucous membranes were hyperemic, and the capillary fill time reduced. The respiratory rate was a bit increased, and we had fever. And when we performed the abdominal palpation, it revealed intense abdominal pain in the cranial cavity. This is a very stoic dog. It means that this was a dog that was hiding the pain that was feeling. And because it is a working dog, and the owner knew about that. So when he first saw that the dog was not eating properly, or that the dog was a very active dog, was actually less active, reduced the activity level, then it was already 3 weeks after the episodes had started. So we are a bit delayed in our diagnosis for 3 weeks. And despite the vomitings, the dehydration was mild, around 7%. So whenever we have a problem with vomitings, we always create a problem list. So now we have a chronic vomiting because it's more than 3 weeks with recent acute deterioration, and we have abdominal pain. We did not have, the body condition score was good, was ideal, actually, 5 out of 9. So the animal was not malnourished yet. But we had a very, very severe abdominal pain. And what about the hematology and biochemistry? We had neutrophilic leukocytosis. So we thought about, extraintestinal diseases, maybe pancreatitis or something like that, with a regenerative left shift. So we had more bands than segmented neutrophils, and we kind of thought about, something septic or an infection, an inflammation of some kind. Monocytosis and eosinophilia. We had an elevated HCT, probably due to dehydration, and mildly increased alkaline phosphatase, but I have to remind you that this is a very young dog. It's a puppy, and it's a large breed puppy, so the alkaline phosphatase could be out of the age. It was not a double-fold increase. It was a very, very mild increase. And we also had electrolyte disturbances like hypochloremia and hypokalemia. So Addison's is pretty much out of the picture. The CPLI was positive for pancreatitis, but beware, is a CPLI the test that you have in your practices always indicative of pancreatitis? No, it could be indicative of duodenitis. Also in Cushing's disease, we can have dogs that give positive CPLI tests. So beware when you interpret your CPLI test. Okay, the ACTH test was normal. Why did I do an ACTH test? Because we always want to exclude the Addison's disease, and because I can really recall that in this animal, the baseline cortisol was in the gray zone. It was around 2 or 1.9, which was really, combined with the bradycardia that we had. We said that we definitely have to exclude that. The lactate was increased due to probably the mild hypoperfusion of the gastric mucosa. And we also had metabolic alkalosis, and I really want to talk about it because in most cases of diarrhea or vomiting cases, we have metabolic acidosis. When do we have metabolic alkalosis? And this is the key here. When you see a patient that's vomiting and has diarrheas, for example, we didn't have diarrheas in this patient, but when you have a GI patient with metabolic alkalosis, then these are the things that you have to consider. First of all, vomiting, any vomiting, and especially with upper GI obstruction, pyloric or duodenal obstruction, we have metabolic alkalosis, and this is a key to our diagnosis in these patients. Maybe when we have overcorrection of hyperventilation with Conn's disease or with Cushing's disease sometimes, iatrogenic, or when we have a total body water loss with the use of diuretics. Okay, this is a very, very important chart to have in mind about metabolic alkalosis. And there are two kinds of metabolic alkalosis, one that's chloride responsive, and the other one which is not chloride, which is chloride resistant, which is not chloride responsive. The chloride responsive metabolic alkalosis is a state that can be corrected with normal saline. And in this type of alkalosis, with fluid therapy with normal saline, as opposed to lactated ringers, for example, or ringers that contain less chloride, is preferable. So in these patients, we use normal saline in order to correct the metabolic alkalosis. And the other, for the resistant one, is the metabolic alkalosis that we see in underlying diseases like Conn's syndrome, okay, or secondary I'm going to say it, and it's a Greek word. I have to pronounce it correctly. Hyperaldosteronism. So this can lead to excessive aldosterone production, which will result in sodium and chloride retention. Okay. And what happens in pyloric obstruction? So we have in pyloric obstruction, whenever you have the suspicion of pyloric obstruction, this triage will actually give you the diagnosis, even if you haven't done any endoscopic procedure. So if you have hypochloremia, hypokalemia, and metabolic alkalosis, then this rings a huge, you know, red flag for pyloric obstruction. And combined with that, in many of these patients, we have paradoxal aciduria because the sodium is reabsorbed by the kidneys, but the potassium is lost through the renin and angiotensin system mechanism. And we have increased excretion of hydrochloride, and this is why we have aciduria. So when the chlorine is reduced, we have bicarbonate reabsorption through the kidneys, which is increased. And this is why we have paradoxal aciduria. So you will see that you have an animal with metabolic alkalosis and the urine is acidic. This rings a bell for pyloric obstruction cases. Let's see what Apache had. This was the X-ray of Apache, and you can see that in the stomach, we see a huge foreign body. And it took us around, I don't recall, 1.5, 2 hours to take all the foreign bodies out of Apache's stomach. But he didn't have a gastrotomy. Is it worth it not to have a gastrotomy? Because I know that the surgeons could have fixed it in, you know, less than 20 minutes. But, you know, the animal after that was bright and alert. It went home. This is the pros and cons of the endoscopic procedure. But this animal had eaten practically everything. I will show you what we have taken out of this stomach. And this has been the case for the last 3 weeks. The animal was actually accumulating foreign body over foreign body. This was not a one-time consumption. This was over these 3 weeks, the animal was consuming foreign bodies. It was actually an allotriophagic animal that was consuming foreign bodies. And why is that the case? We will see that later. So you can see that this is the first, you know, view after we got into the stomach full of foreign bodies, but we cannot actually discern what is what. And when you are guided into the pyloric region, we actually try to inflate the stomach right now so that we can see, you can see Excalibur in here. You're going to see a lot of things in there. This is a washing for the plates sponge, which is metallic actually. And I'm trying to guide myself into the pylorus, which I will do now in the next video. And we're trying to untangle the foreign bodies in order to bring them out from the cardia, which was very, very hard because the masses of the foreign bodies were so big, but you really need to do torquing movements and be patient. So as you see, we're trying to take out all the foreign bodies and go and look into the pylorus again. Now I have some tension. You see how the esophagus is folding onto my forceps and onto the foreign body here, for example. I don't know if you see my the sensor. When there is a lot of tension, this is the time to stop. This is not the time to go and push harder out, to pull, not to push, to pull. This is the time to go to dive back in and see what's going on. Why am I pulling? Because it was coming. I had the sense that something was coming. And there was a huge ball of materials in the cardia. And this was a little bit later, after removing the foreign bodies and inspecting the stomach for ulcers, for ulcerated regions. You see that we have some erosions and ulcers due to the foreign bodies that were obstructing the pylorus. But moreover, if you compare the amount of foreign bodies that this stomach had compared to the lesions that were actually afterwards, that we see after the removal of the foreign bodies, then the comparison is in favor of the patient. We have some dotted ulcers everywhere, but it's not, a huge problem for the patient. And right after the patient was recovered, it went home back to normal, to his normal appetite and to his normal activity. The problem with this patient is that it was also feverish, febrile, and this is something that we really have to remark. And the elevation of the white blood cells count that I want to talk to you about. We have an open pylorus, which is not very good because we're going to have duodeноgastric reflux disease as well. But this is due to the obstruction, to the prior obstruction. And this is what we actually have found in his stomach, like towels, a sock. It was some kind of an orthopedic device for the daughter of the owner, who was an athlete, a volleyball player, and something to wash the plates. So we have a huge collection of foreign bodies in Apache's stomach. But I really want you to be aware of these cases, because an animal that exhibits pica like that has probably an underlying disease. Could it be Addison's? We excluded for this patient Addison's. Could it be Addison's? Could it be an infiltrative disease, an inflammatory bowel disease? Could it be something else? But we always have to look for an underlying disease when we see animals that have this tendency to have pica. Could it be exocrine pancreatic insufficiency? Not for these patients, I mean in general. But you really have to, because these patients will be readmitted to your clinic with foreign bodies again. So you really have to solve the problem, and taking out the foreign bodies is not the ultimate solution. The ultimate solution is actually finding out which underlying disease triggers pica. Okay, and let's go to this one. This is a very, very recent case. It happened this Christmas. So we have this mixed breed female intact 1-year-old patient, and Lily had an accidental ingestion of 10 tabs of meloxicam, that were actually originally for human use. The trade name of the drug was Movatec, 50 milligrams per tab. 2 weeks prior admission to our referral hospital. So Lily consumed the pills with the package and with everything I'm going to show you 2 weeks prior to admittance in our clinic. So she went to her doctor with hematemesis, melena, severe depression, abdominal pain, very, very low hematocrit, 16 due to the non-steroidals, and the doctor there presumed that some gastric ulceration and ongoing hemorrhage, and he was very correct about that. And gastric hemorrhage was on an ongoing process. So she was hospitalized for 5 days, undergone a blood transfusion, got much better. But during hospitalization and post-hospitalization, even though her appetite was really, really good, was restored, and she did not have any dehydration anymore, the vomitings remained frequent 3 to 4 times per day, even though she was fed this liquid diet. And it was like 3 to 12 hours after the meal. Her stomach, according to the owner, was distending so much that the owner actually was afraid of gastric, torsion in this patient, which is a small breed patient. And it wouldn't, we wouldn't normally have a distension. So you will see that she's really keen into eating, but even this liquid diet, she would vomit it. So she wouldn't tolerate not even the liquid diet, okay? And it was not regurgitation, it was vomiting. Unresponsive to any antiemetic treatment. So 2 weeks post-hospitalization, despite the administration of meropetam, metoclopramide, lansoprazole, sucralfate, they've given pretty much everything. The vomiting episodes insisted, and due to a marked increase in the white blood cells count, the referring vet actually prescribed amoxicillin and clavulanic acid, which was administered subcutaneously because it couldn't remain in the stomach per os orally. And cobalamin was also administered at a dosage of 1 milligram on a weekly subcutaneous injection due to malnutrition. You see that she was severely emaciated. And upon admission to the clinic, the patient did not present any signs of hematemesis or melena. So when she came to us 2 weeks after all this adventure, Lily only had the problem of intractable vomiting. She was still pale on physical examination. And this was actually her, the vomiting that she did, hematemesis, and the vomiting that she did right after the ingestion of the whole drug, with the paper, with the instructions, and with all the non-steroidals. And this was at initial presentation before admitting to our clinic. This was at initial presentation, the melena and the abdominal discomfort. She was just staying like that, exhibiting immense abdominal pain. So when she came to us, the physical examination, she came like that. The physical examination findings, she still had marked abdominal discomfort and pain when palpating the abdomen. The body condition score was 1 out of 9. And as we said, we always not only estimate the body condition score, we estimate also the muscle condition score, which was D. She had lost a lot of muscle mass. It was more than 1 month, an ongoing process of this case. The respiratory rate normal, the beats per minute mildly increased. The mucous membranes were still pale, but not that pale. And the temperature normal. The fecal score was absolutely normal. Whatever passed through the duodenum, she had normal feces. She had no diarrhea. Okay, and I always estimate in vomiting patients the CBDI and the CCI score, which was 6, which was not bad. And as we said, we always create a problem list. And what were our problems right now? The uncontrolled vomiting, the weight loss, and the anemia, the still persisting anemia. What are your thoughts about Lily? And this is a very, very recent case. We had it now during Christmas time. Do you want to write something in the Q&As? What do you think? How should we proceed from there? What do you think we should do in order to investigate these three components in our problem list? Any ideas? Okay, let me tell you what we did. And she probably has a very artistic owner with the paintings. Okay, what are the most common abnormalities in dogs and cats with GI ulcerations? Because at that point, we didn't know if we would still have ulcers or if the ulcers are if the ulcers were healed. Okay, great. Agenda. Any test for tick disease and endoscopy as well. Yeah. So we can have anemia in gastric ulcerations. We can have anemia, and we can also have signs of iron deficiency when we have chronic bleeding. Most of these patients have an elevated urea with normal creatinine. Okay, and also we can have microcytosis and hypochromia, and of course, low total proteins count due to the ongoing hemorrhage in these patients. So let's see what Lily had. So upon admittance, when she had first ingested the non-steroidals, her first HCT was 28.5, then she had 16, and then after, because we did Windrop, okay, and then after that, after the blood transfusion, the HCT got better, okay, and that was after the antibiotic treatment because we had an elevation in the white blood cell count, as we said. And then 30 days, when actually was admitted to us, the HCT was not that bad, was 34.9. And the white blood cell count was normal. Still vomiting, though. Okay. And this was Lily upon presentation to us. You see that she's very quiet. She's bending a bit, showing abdominal discomfort. So with chronic gastrointestinal hemorrhage, what we have is microcytic hyperchromia, hyperchronic, and pre-regenerative anemia. Regenerative, and we also have to think about the pre-regenerative fact that if you see a normal hematocrit in an ongoing hemorrhage, you will have to wait at least 3 days in order to see if the regeneration will start. Okay, thrombocytosis, low ferritin, and low ferrin binding capacity due to the chronicity. And we have depletion of ferrin. And let's see what her biochemicals on the admission in our clinic was. All the biochemicals were normal, cholesterol, total proteins. So she did not have an ongoing hemorrhage at that point, but we did have hypokalemia. The baseline cortisol was normal. So we excluded hypoadrenocorticism, and we didn't have to perform the HCTH test. And we also did a DGR lipase in order to exclude pancreatitis as well, because we had previously the white blood cell, the elevated white blood cells count, and it was normal. We also, this was actually her imaging, her ultrasound at the day of the first admittance, not at the day of not at the day that she was admitted to us. So you see that back then, when she had ingested the non-steroidals, she had multifocal gastropathy, consistent with some kind of an inflammatory process, and active gastric ulceration, an inflammation of the duodenum, and we also had lymphadenopathy of the pancreatic lymph node, bilateral renal disease. It was non-steroidals, don't forget, and a mild splenomegaly. And these were the images from the duodenum, the right adrenal gland, the kidneys, the stomach, and the liver. And what we did, because she had this ongoing hemorrhage, we decided to do a barium contrast study in order to see what was wrong in the gastric outflow of this patient. You can do fluoroscopy. We will discuss in the next webinar what are our diagnostic modalities for gastric for gastric outflow and for gastric motility disorders. So we did a barium construct study, and we were looking for the string sign. And what is the string sign? This is the string sign. This is the sign that shows that a very, very small thread of food is projected through from the pylorus into the duodenum. Okay, this is what we were looking for, and this is Lily's barium study. So this was before the barium administration, and this was at 0. The minute we gave her the meal, we did the x-ray. We have a very small thread here of barium, but all the food progressed into the stomach. And then in 45 minutes, still the stomach full. In 2 hours, we started seeing some material promoting gastric content being promoted from the stomach into the intestines. So in general, we have to have an emptying stomach. After 6 hours, the stomach should be empty. But if it is more than 12 hours retained in the stomach, then we definitely have gastric hypomotility. This was in 4 hours, and please beware and take also DV radiographs, not only lateral, because they give you a better view of the pylorus, of the pyloric region. This was in 7 hours. You see that we have loss of feeling in the stomach. These are areas that have been emptying during these hours. 12 hours, we still have a lot of material retained in the pyloric region mostly, whereas the fundus has been emptied. And 16 hours, still having content in the stomach. And 24 hours later, though, the stomach was empty and everything has proceeded into the large intestine as well. So we definitely had gastric hypomotility, and we went into exploring what was wrong. So in our first endoscopic procedure, you will see that even in, it was not performed the day of the x-rays, 3 or 4 days afterwards, Lily came to be scoped again, and you will see that she had retention, even though we said, 16 hours of fasting, she did have retention of food in the stomach. And we have diffuse gastritis, a diffuse gastritis pattern with some erosions and edema that you will see better here in the antral region. You will see an overfolded pyloric sphincter with ulcers and some erosions and ulcers that I showed you, but the passage to the pylorus was not accomplished. So what we at that point, because we've seen that the ulcers were healed, so at that point what we did is that we took endoscopic biopsies. And what was the result of these endoscopic biopsies? Let's see. We took these endoscopic biopsies, and we didn't proceed at that time in surgery because we were waiting for the endoscopic biopsies to come round. This is the incisor angularis, the fundus, and the pyloric region. So the histopathology, and this is where I really want to highlight that, because you will see that our final diagnosis is totally different than our endoscopic diagnosis. So the histopathology from the endoscopic biopsies revealed that we had mild lymphoplasmacytic gastritis with mild fibrosis. Okay. And we didn't have any Helicobacter-like organisms. So once we saw that we had mild lymphoplasmacytic gastritis, we said, okay, let's take it more conservatively and give other antiemetic agents, maybe combine antiemetic agents, maybe give prokinetic agent, because we also gave cisapride here. So we gave ondansetron instead of only maropitant or metoclopramide, and low-fat diet so that it can, really be quickly promoted, but it was not responsive. And she was vomiting 2 to 3 times per day, but her appetite was restored and she was kept on losing weight. So what we said at that point is that we're going to go in and see what's really going on right now. So we went for a second endoscopic procedure. We had severe pyloric stenosis, severe, as you can see their hyperproliferative tissue obstructing the pylorus, and the passage is just one thread. We were actually misguided by our barium contrast meal, which showed that, okay, maybe we had a delayed promotion of the content, but it was promoted eventually. And we also were misguided by our first endoscopic biopsies diagnosis, which said that it was mild fibrosis and lymphoplasmacytic infiltration, which of course was not inflammatory bowel disease, but it was an infiltration. So I went in and you can see how much of a stenotic, it could only a urine catheter could pass through that. Not even, it was even smaller. The passage of the pylorus was even smaller than the opening of my forceps. So I went in and see what's going on with my forceps so that you can compare the size of my forceps with the stenosis. And not even my forceps could go in through this stenotic region. It was actually a pyloric stricture, not even a stenosis. You see that even my forceps cannot pass through this strictured area. Okay, and of course I could not intubate the pylorus, not even with the assistance of the biopsy forceps, because if you have trouble sometimes intubating the pylorus, what you can do is proceed with the forceps and then your scope will follow. And this can also happen in the ileocolic valve when you want to intubate the ileus. You can do the same technique. So the good thing is that we had no active ulcers. You can see how stenotic the pylorus is here as well in this view. And how overfolded and thickened it is, but no ulcers as the previous time, as we had in the first endoscopic procedure, which was closer to the non-steroidal ingestion. And this is the incisor angularis, this is the fundus and the body, and here the antral region. Okay, so the overall view of the stomach is much better, but the pylorus is very, very tightened. So we had to follow a different therapeutic plan, which of course was to restore the fluid and electrolyte disturbances and to restore the gastric mucosal barrier with sulcrophate and omeprazole. And of course, we administer antiemetics and a prokinetic agent, low-fat diet and surgical, all of those things after the surgical management. And there are 3 techniques for those of you who asked before. The piloromyotomy, the Heineken Mikulich, which is very, very common, and the YU piloroplasty. We actually perform YU piloroplasty in Lily, and this is the procedure. So you create this V form, you open the pylorus and you create this V flap. And of course, when you do that, you always send to the histopathologist full thickness biopsy of your of the piece that you extracted, that you excised. And what it showed was that we had hypertrophy of the circular smooth muscle and a suspected ulcer remnant. So we definitely had piloropathy. Hypertrophic piloropathy secondary to the ingestion of the non-steroidals, which was not actually diagnosed in our endoscopic biopsies. And as we said before, it could have the congenital form. In our case, it was the acquired form. It could be in any breed it's overrepresented in brachycephalic breeds as a form of a disease, but it could be presented in any breed that has chronic inflammation, chronic vomiting, or gastric ulcers. In our case, it was gastric ulcers. We can have 3 types. Type 1, which is the primary circular muscle hypertrophy, type 2 and type 3, with primarily mucosal hyperplasia. We had type 1, which was, in this case, which was circular muscle hypertrophy. We didn't have mucosal hyperplasia. And of course, the cause is the increased gastric concentrations or the changes in the mesenteric plexus that lead to chronic antral distension. In our case, it was the ingestion of non-steroidals that caused severe fibrosis, gastritis and fibrosis in the pyloric region. And this was 5 days post-op. She had started to regain some weight, not in 5 days, but in 10 days, you will see that she's much better, but she's very bright and alert. She doesn't vomit at all right now. She had a bit of a problem right after the 1 or 2 days after the piloroplasty. She had gastric distension due to gastric hypomotility, gastric paresis, but we solved that with cisapride. And we're going to talk a lot about prokinetic agents in our next webinar. We're going to present 2 more cases of different etiology, of different causes that caused pyloric obstruction. And this is 10 days. This is her 10 days having gained weight and be very, very active and very happy. No abdominal discomfort, no pain at all. So this is all for today. I hope that I was on time. This was all for today. And please, thank you all for your interest in veterinary science and in endoscopy and endoscopic procedures. And I think that it's time, for us to a bit discuss. If you have any of your cases that you want us to discuss, or if you have any remarks or something that's troubling you, I'm very happy. Okay, let's see. The questions. Oh, I can't wait to see you next time as well. Hi, Babak. How are you? Can we do endoscopy in the GDV case and evaluate the stomach? It's very, very easy. What we do in our everyday practice is the easiest and most immediate examination in our patients. And what is the most immediate and easy examination in our emergency patients, the radiography. With the radiography, you can see if the distension is ascites, or you can also have your clinical history, which says that your owner says that the animal was fine. He ate his food, his meal. Yeah, most of the times I don't know, it's evening meal. So they wake us up at 3 o'clock after midnight. And then it got distended. So you do not put a comprised patient, because these patients are very, very are emergency patients, and they do not have a good perfusion. So they're very risk anesthetic patients. So you do not put for anesthesia an animal that you suspect of GDV. This is the first thing. And the second one is that you have your lactate in order to evaluate if you have necrosis, for example, if you have gastric necrosis. And you also have your radiograph, which is very, very easy. So you first stabilize these patients, and then you diagnose what it's all about. And then you go for endoscopy or surgery or whatever. And these patients also have a lot of, the GDV patients have a lot of electrolyte disturbances in terms of potassium, for example. And it's very, very dangerous to put them under anesthesia. So I hope this answers your question. I wouldn't put a GDV patient just to diagnose GDV. Is it safe to use barium sulfate in a vomiting dog because of the risk of aspiration pneumonia? That's a very, very good question. This is why we do not do liquid barium, but we do a meal, a barium meal with a canned food, together with canned food. But yes, this could always be the case. But you do have to somehow diagnose, if you have a gastric hypomotility disorder. And if you have excluded, for example, full mechanical obstruction due to a foreign body, then as you saw, some of the food, some of the gastric content was promoted to the intestine. You cannot take a biopsy when the scope head is in J maneuver. Even if I pass the biopsy forceps first, because the scope head is not bending enough. Okay, no, it's not normal. What you can do is just give rice. What you can do is you will definitely be able to take a biopsy in J maneuver, and we can also retrieve foreign bodies in J maneuver. But you need to give angulation with your body most of the times. If you cannot do it with the forceps, you can do it with the nodes, because this is a problem. You do not have very many moves with your nodes when you're in J maneuver. But what you can do is torque with torquing, taking it in and out, and bending your scope with your body outside. Endoscopists are like dancers. You have to learn a new dance, Babak, and it's a matter of experience, especially with your scope, which is a very good scope. Antoine, thank you for the for the attendance as well. Thank you all of you that attended. I'm really, really grateful to all my colleagues for sharing our experiences. And I would love some endoscopists also, some more experienced endoscopists to attend, so that we can have, an interaction as well with their cases. Thank you, Hussam, as well. Thank you for attending. Are there any more questions? If you have any other questions, if you want to come in contact with me, please don't hesitate to send me an email, to find me in social media, to address to Aohua in order to find me. My next workshop will be with Aohua in Singapore. So for those of you who are very close to Singapore, we can you can all come, and I will be very, very glad and happy to see you all there.
Yes.
Thank you, Futinulam,
Yeah.
for attending.
For the next workshop, it will start at the 1st of March in 2024. Yeah, so some information will be posted on the social media. So please follow us, and you will receive the latest news.
Definitely. The next webinar will be in February, and the next workshop will be held in Singapore.
Yeah.
For those of you who are from these regions. Hi, Milan. My best wishes to Serbia and my best wishes to all of you for a very, very happy new year. See you all next month.
Hey, thank you for the brilliant presentation. See you next time.
See you all next time. Bye.
Bye. Bye.